was also a question in the chat asking about more rare mutations, RET, for example, if there were any opportunities for trials for early stage patients to receive targeted therapy that have more rare targetable mutations.
Yeah, so there are studies ongoing. For example, with RET, the libretto studies. That's kind of the generic name of these RET target therapies. With I believe that's with selpercatinib, given either before surgery or after surgery. But again, I think this is a scenario where if we don't have data, but we know we have highly effective targeted agents that have good CNS penetration and are relatively well tolerated, I think that's where you can really have a discussion with your provider of, is an off-label use of this appropriate in this scenario? I mean, I think the RET targeted agents do check a lot of those boxes, again, of an agent that is effective with good penetration into the brain and that's reasonably well tolerated, where I think an approach similar to osimertinib after surgery, similar to ADAURA, can be mirrored for these patients.
I think the two key messages of several others that all of the attendees are hearing today from all of you speakers is that, one, you have to make sure all the biomarker testing has been performed, right? Because that is the starting point for all of our discussions today. And second, that after in the postoperative setting or perioperative setting, we not to just default to immunotherapy. Even if, for example, PD-L1 biomarker level is high for these certain targetable genomic subsets of lung cancer, just defaulting to pembrolizumab or atezolizumab after concurrent approval for these agents. And so those two things I would really encourage all of the attendees to remember is making sure all the genotyping and biomarker testing has been done, and then making sure we are not just defaulting to immunotherapy depending on the specific type of lung cancer that you have.